Welcome back to this episode of Clinical Communication, which this episode is all about male pelvic pain and related issues. My guest on this episode is Bill Taylor. Bill's a specialist physio and educator across many pelvic issues, but has a particular interest in male pelvic pain. On this episode, we're discussing how we can help men feel more comfortable discussing their pelvic related issues, how we can encourage them to open up and discuss the areas of their lives that are affected, and how we can ask the deeper, more difficult questions that come with this area. If you find this useful, please do go share it with others. Please do subscribe. You can find Bill and I on social media. I've put the links in the description. Thank you as always for watching or listening, and I'll speak to you next time. If you are bonding with someone and you're
Yeah,
building rapport, they
yeah,
will begin to copy you,
yeah,
mirror you. So
yeah.
clearly you're building lots of rapport, Bill.
And I
Uh,
think, yeah, and I think that's so. I think a lot of my patients, it's kind of a bit of a pelvic health patients are really unique in that every single one of them presents in a different way. They're like
mm,
lots of pain patients. They're like lots of patients with chronic or complex presentations,
mm,
with lots of things going on, who've and they're very, very different, but they've often all had this same journey of ever increasing medical interventions, ever
mm,
decreasing returns, many, many, many consultations
mm,
with no decent outcome, with no sense of anyone making sense of what's happening to them.
mm,
Everyone trying to squeeze them into a diagnostic hole that they don't fit into,
mm,
and they know they don't fit into it, and and sometimes even the clinicians know they don't fit into it, but they have no other tangible thing to offer them. So they often come to me feeling. I always say to my patients, you think you're here because you want me to treat your pain. I
mm,
said, no, I can't treat your pain because it's like catching West Highland Terriers on a football pitch. I said, I'd be running all over the place and I wouldn't catch one of them.
mm,
I said, so, but what I can I said, but what you're really here for is because you feel hopeless and you feel miserable and you feel lost. I
mm,
said, and you've lost the joy in your life and you're not living. And
mm.
they kind of go, okay. And I'll
Mm.
say, so my job is really to give you hope, reduce your misery, and help you back on a path to independence and actually my job isn't to fix you. My job is to help you on that journey, and I'll come on it with you. But and I said, if it's a big burden, if you feel it's such a big burden, you can take the yoke off if you want. You can leave it here. We'll stick it in the corner. I'll look after it for you. You don't need to. I won't carry it around, but I'll keep it here. There's a pile over there already. Stick it over there.
Yeah.
I said, and you can actually, I said, metaphorically, just leave that here. I said, and then I'm a bit of a pragmatist, and I'll say, so I don't know, how does that sound? Does that sound like something that you would be interested in working me with? And they kind of, yeah, I would. And I said, so what was the last thing that anyone said to you medically? What was your last consultation? And they all say to me, well, I was told there's nothing that can be done, and I have to learn to live with this.
Mm.
And I'll say, and how did that make you feel? And there's a lot of kind of difficulty in answering that question because, of course, the answer is it made me feel like I didn't want to live. It
Yeah.
made me feel like I don't want to be here. And in actual fact, I've had suicidal ideation, and you're the first person that's probably got close to asking me that question. And it's like it's an emotional moment. It's quite a pivotal moment.
Mm.
And I will say to them things like, I said, I can see that you're really upset about this. And I said, and I can't imagine that you could be any other way. And why would you expect to be having
Mm.
had the journey you're having and then to be told that there's nothing that can be done? And so I kind of lay out the land quite, it's quite, I suppose it's quite deep and
Yes.
it's to the point, but
Yeah.
I'm kind of, and it might be, and I might not, I might have listened to them for quite a while by this. So because I normally just sit down and they'll kind of say, there's a few little tips that they'll say things like, well, I said, where, oh, right. So how can I help you? And they'll say, well, it's complicated.
Yeah.
And I'll say, okay, that's fine. I said, that's good. I said, complex, complicated is good. That's what I do. So tell me your story.
Mm.
And they'll say, um, oh, from because they then because what their experience has been, they've been shut down. Their experience has been
Yeah.
the practitioners before don't want to hear everything.
Mm.
They want to filter out what they want to hear.
Mm.
And they go, what do you want? Like, it's a really long story. I said, well, from the beginning, that's good. Do that.
Yeah. Yeah.
And they'll go, the whole thing. I want the whole thing. And so they tell you the whole story. And and it's the biggest thing I've had to learn in my practice because I talk far too much, is to actually shut up and listen.
Mm.
And so I actually physically have a bit of a technique for that where I sit on my hands. And
Ah.
if I'm actually sitting on my hands, I'm not allowed to talk.
Mm.
And if I want to talk, I've got to take one of my hands. I'll have one of my hands under my thigh, and I'll kind of sit there and just say nothing. And if I want to talk, I'll take it out, and then I'll
Okay.
talk. And when I'm finished, I'll stick it back in to remind me to shut up again, because otherwise I'll ramble on.
Mm.
And I just really listen to their story. And I think one of the things I've really come to realize is that in a kind of a biomedical model where we're looking for diagnoses, most of our diagnoses comes from the patient's history.
Yeah.
You know, most of it comes from what they actually tell us. And my old professor, one of the things I say many times when I'm speaking is listen to your patients because they'll tell you what's wrong with them.
Mm.
And my old professor used to say, but listen to them a little bit more because if you listen to them a little bit more, they'll tell you how to fix them.
Mm.
And the patients do have the answers in there if we can tease them out. So I'll kind of listen, and then my kind of approach is to say, okay, so your history fits the pattern and the themes that I've heard many times before.
Yeah.
And I'll say, but you're in a complex arena
Mm.
where we're only really coming to decide and make sense. And I try to not use things like diagnosis. I'll say we're trying to make sense of what you're experiencing
Yeah.
in hindsight. So we're trying to look back at all of the tests, all of the things you've had done,
Mm.
as because you were just straightforward and you went to the doctor and they gave you antibiotics for your infection and that didn't go away. Because a lot of these guys are diagnosed chronic pelvic pain syndrome. They're
Mm.
diagnosed with a chronic prostate infection. And I said, then what happens is that doesn't get better. So you go into the complicated quadrant where they do
Yeah.
tests and they try to decide what's wrong with you. And they give you more complicated medications. They give you cystoscopies, MRI scans. They give you all of these tests and they say there is nothing wrong with you. I said, that statement isn't quite true. What they should say is there is nothing that we can find wrong with you on the tests that we have done, which
Mm.
is much more honest than there
Yes.
is nothing wrong with you, because there is nothing wrong with you immediately is the first time that you think it's in my head and this doctor thinks I'm making it up.
Mm.
And
Yes.
then the second thing you think is I'm not believed. So I'm also dismissed. And I'm also made to feel a little bit humiliated because I have come with all of these horrible symptoms.
Yeah.
And I've come to the doctor and I'm hoping you're going to heal me. You're going to fix me. You're going to cure me. And you're beginning to sound that you're not going to do that. And I think the fear kicks in then. They become very afraid that
Yeah.
because they think, well, if he doesn't know what he's doing and he's the consultant, how do I go forward with this? So I think I say to them, look, you know, the doctors have done all they can. They've done all the tests. I said that's, and I reframe it a bit for them. I'll say that's really useful. It's
Mm.
really, really useful to know that you don't have this, and this. It's really useful that the scan was normal. I said it's really useful that all of the tests for infection are negative. I said, so that's great. So now we can make sense of where you are, and we
Mm.
don't need to worry that there's something there that's serious, that's outside my remit that I wouldn't be I wouldn't be able to treat you for.
Yeah.
And so I think then I have this kind of pattern where I'll say to them, so what we're going to do today is, I said, I have 4 or 5 boxes that I like to tick. And if we
Yeah.
can tick all those boxes, then you fit a pattern. I
Mm.
said, and I put you in, if you, I make sense of what you have. I said, and I give you an umbrella term. It's not a diagnosis because I've made it up. And it's called complex pelvic pain syndrome. I said, it doesn't actually exist because it's called chronic pelvic pain syndrome. I said, but I don't like chronic because it
Mm,
implies it can't get better.
mm,
I said, and so I think this can get better. I think you can get better.
mm,
And I mean, I know what I'm doing is I'm giving, and I'll say, and I know you think I'm telling you this because you want to hear it. I said, but I've seen thousands and thousands of patients with this. So part of my sense of hope that I'm giving you
yeah.
is because I have audited my patients and I know what I do with them and I know they get better and I measure their improvement and I've seen that improvement. So it's not just my opinion. They tell me they get better and we've measured that. I said, so it's not just me saying this so that you feel better. I'm actually saying based on, I said, and I said, there's not been any research on this. So the only thing I can give you is my anecdotal knowledge and the fact that I've seen lots of people. I said, the way I look at it is when you come to see me, I collect the data. I try to develop a hypothesis and then I try to reject it. And if I can't reject it, I have to accept it. And my
Mm,
box ticking lets me accept it or reject it.
mm,
I said, and if I have to accept it, so I said, because otherwise everyone I see has pelvic floor disorder. I said, so I have to try and assume you don't and prove that you don't. And if I can't prove you don't, I have to accept you do.
yeah.
By that point, they're looking at me going, this boy's mental. What is he talking about? But I'll say, but actually, they kind of get it a bit later. And they'll often say, oh, see that thing you said the first day? I didn't really get it, but I understand now what you were saying. And it's to try to minimize my bias, because of course, I think that the history tells me that. But I do stuff like I've had the conversation. I'll then look for tender in the internet I'll look for tender spots in muscles. I'll look for sensitized areas in nerve. I'll look for change in breathing patterns. I'll look for um, tension in the pelvic floor externally, tension in the pelvic floor internally. I'll measure EMG output if I need to
Mm,
see whether or not the muscles are not switching, are they switching on and off or not? And then I'll use ultrasound imaging to see what the movement of the pelvic floor is like biofeedback wise. So I'll kind of like cluster my tests to say, look, one of these tests means nothing, but an accumulation of these tests could mean something. I said, so it's like, and then I said, if you get a tick for each one of these tests, then the bigger the likelihood that you fit in that umbrella of complex
yeah.
pain.
Yeah, yeah.
I said, so if you sit under that complex pelvic pain, I said, what does that feel like to you if I say that? And they say, well, you're the only one that said that you can do anything to help. I'll say, okay. I'll say, fine. Right, okay. So this, and then I'll say, and then I explain to them what the examination is going to look like because they're still fearful of the whole situation. And I'll say, look, internal exam is the very last thing that I will do if I need to. The external exam, the ultrasound, and then the EMG, and then the internal if I need to do that. But I don't actually use a lot of EMG, but I do have it there because it's a tool if you've got a complicated patient that you need it for. But normally, I get enough information with my physical hand assessment and my movement assessment tied in with what they're telling me to give me a plan to go forward. And then I say to them, so now this is what, so I'll say, this is what I think this is the umbrella I think you sit under. With under
Mm,
that umbrella, you might have a bias towards being more of a neurally driven patient or a muscular driven patient or a combination of both, or maybe even I said, or maybe some breathing issue, maybe some pressure system management. I said, or maybe the way, and I say to them, so they then ask me, the next question they ask me is, how did I get this?
mm,
And I'll say, okay, well, I said, I'll tell you, I've got a theory. I said, do you want to hear my theory? And so this is my theory. I'll say, so we are born as kids and we're put in nappies and we're allowed to pee and poo at will.
yep, yep.
And then we get potty trained. And the very important word there is trained.
Hmm,
So
yep.
we're not just allowed to pee and poo at will. And then peeing and pooing is horrible, disgusting. People don't want to see it. We want to hide it away. You want to shut the toilet door. You then go to nursery where you're trained. You're continent of feces and urine. You go to nursery and you're allowed to go to the toilet whenever you want. And then primary one, you're allowed to go, but they say, did you try going at break?
Mm.
And then primary two, primary three, you're said, well, I think could you just wait to break? Would that be okay? It's just like an hour. Would that be okay? Could you wait an hour? So we start learning to hold in our
Mm.
urine,
Yes.
our feces. And we then, it's also, you can't need to go to the toilet now. So a little humiliation thrown
Yeah.
in.
Yeah.
Do you say, oh, just put my hand down? What is it? Do you need to go? No, what is it? You need to go again. And then everyone
Mm.
laughs. So you stop asking. So we do that for a while. Then somewhere in the playground, round about maybe 11 or 10, there's a girl or a bloke or a girl who said, oh, you look a bit fat. So you suck in your tummy.
Ah.
You don't ever stop sucking in your tummy because being fat is not cool and being
Mm.
fat is not Instagram friendly. And,
Mm.
and I don't think it matters gender. You just suck in your tummy and you keep it there. And then you get to masturbation and you start masturbating. And when we masturbate, there's all these myths about sex, about how long you're meant to last.
Mm.
And I think we were talking a little bit earlier about how you're meant to last 2.5 minutes. But actually, and where do you learn about sex? From porn on your phone because it's so accessible and it's ubiquitous, it's everywhere. So you start thinking, well, that porn star went for a whole hour. Geez,
Mm.
if I'm going to be with a girl, I better practice going for a while.
Mm.
So what happens is you start masturbating, but you start delaying orgasm. And then you start thinking, I'd like my orgasm to be super strong and powerful. So you start squeezing your thighs together or squeezing your
Mm.
glute or thrusting in the air or doing something that mimics the sexual act. And suddenly, if you think of all these stages, instead of being a nice, relaxed pelvic floor, you get this pelvic floor that gets tenser and tenser and tenser and tenser.
Mm.
And then it might well be, and this is my theory, and it is totally a theory. I've
Okay.
not read anything that supports this at all. But what happens is we become a bit tense, and we might hold our tension in our shoulders and our neck, and it gives us headaches. We hold it in our stomach, and it gives us ulcers. We hold it in our gut, and it gives us IBS, and we hold it in our pelvic floor, and it gives
Mm.
us complex pelvic floor dysfunction, all related, and it's all connected to the muscles are all connected to erectile function and ejaculation. And if
Mm.
that thing continues, it's almost like something tips us over the edge. And the number of times, and one of the reasons I started thinking this was because um, patients would say to me, you would treat them for maybe 3 or 4 months, and then they would come in one day and they said, I think I've had this for a lot longer
Yeah.
than 2 years. I
Mm.
think I've had this. I remember now when I was wetting the bed in enuresis and nighttime nocturia, peeing the bed and peeing at night, or getting up for a pee and then not being able to even know or have the sense that you're peeing.
Yeah.
Um, I think is all tied in with early pelvic floor dysfunction.
Mm.
And when they go, yeah, I'm absolutely sure. And that's I don't really even ask them that. They normally volunteer that when they'll reflect upon it. And so I think and then we're kind of at this stage, and so what do we do? Like what do we talk about? And it's like I think I've definitely moved from I've been a physio for 40 years. So I definitely was of the I remember my professor at school saying to me, at physio school saying to me, don't ask the patient to do it, tell them to do it.
Oh.
Don't make a request, you're instructing them what to do. And I remember then thinking, I'm a bit grumpy. I think if somebody told me what to do, I'd probably tell them where to
Yeah.
go.
Yeah.
So I've never really done that, but I know that can be a thing in physio where people tell patients
Mm.
to. And of course, often as soon as you're told to do something, what are you going to do? Well, unless you've given a supremely good reason to do it, you're not going to do it, are you? You're going to go, I'm not doing that.
No.
So it's kind of like I think I think you're right. I think I think you're the thing about generating that rapport to then develop that patient-therapist alliance, which is what all of that history is about, trying to. Because the other thing that I would say, I should have probably said at the outset, is I assume I'm like adverse childhood trauma precautions globally. So
Mm,
I assume every single person that I see with pelvic floor dysfunction has had an adverse childhood trauma.
mm,
Whatever that is, emotional, sexual, physical, it doesn't really matter. It makes no difference to the actual experience that they have and the trauma that they feel, because they're
yeah,
still going to have that trauma.
yeah,
And some people can have fairly horrible sexual experiences and have quite minimal trauma, and some people can have, really kind of really quite horrible, are really small physical things, but that cause really big trauma because of whatever happened to them at the time. So I mean, and I'm not a trauma expert, but I definitely just assume everyone has had that and be very cognizant that that might arise during the whole session.
yeah. How do you find, because I get asked this as well, but they're asking whether it's about adverse childhood events, or other, to use your word, deep things.
Yeah.
And I get asked this, and I don't always know how to answer it because I like to be a bit like Mr. Nosy, like get to know the about stuff, and I find it interesting as well. Asking those deep questions, like, how did you feel about that, and
Yeah.
you know, I
So
guess, how did you feel more comfortable asking those? 'Cause it's not, especially when you start out, it's not something
it's really
you're
hard.
used
I
to
mean,
asking.
I think this, I sometimes think, so I was looking at a slide that I wrote for a talk recently, and it
Mm,
said, how do you talk to men about these things?
yeah.
And the very first thing I said, don't ask about emotions.
Okay.
Like, first, don't go in and go, so how are you feeling?
Mm.
Because the answer is fine. That's how I'm feeling, right?
Yeah.
And so it's like what so what I tend to find is if you work in the field for a long time,
Mm.
you get an intuition or a sense that there is something happening deeper
Mm.
than what that patient is sharing with you.
Yeah. Yeah.
My feeling is that and I think speaking to counselors, and I've done a little bit of kind of supervision
Mhm.
work with counselors, which is really, really helpful because I think we're not trained as physios to do this, right?
Not
And so,
properly. No.
and actually, psychologists, social workers, people that are working in the trauma arena are mandated to go and have supervision. They
Yeah.
can't not do it.
Yeah.
So I kind of made that choice to have some supervision. And actually, that was the best thing I did because it kind of helped me answer the question that you've just asked. And I think the thing is, so I get this feeling if they don't want me to ask it, then I don't. Because
Mm. Yeah.
because all I'm going to do is open a can of worms that I'm not qualified to help with.
Yeah.
And so I will make a note somewhere mentally or in their notes to say, um, I think there's a high likelihood of adverse childhood trauma here.
Yeah.
And I will leave it at that. And it might well be, so this is my plan because I'm not a counselor. And I would say I would then treat them because sometimes if you treat the physical thing, the emotional thing gets better.
Yeah.
And if you treat the emotional thing, the physical thing gets better. We kind of know that. There's some
Mm.
evidence out there to support that.
Mm.
So my job as a physio is to help what they've presented to me with. And perhaps what I would then do, if let's say they're maybe not improving as well, or we are a little bit stuck on our journey,
Mm.
I might say to them, so I'll have a kind of so let's say things are going well, and then they come in and they say, in fact, it happened just the other day with a patient where he said, I thought, he said, when I came to see you, Bill, it made such a difference. He'd done a kind of psychological approach to his pain and it hadn't helped. And I said to him, it was really interesting. It was actually, I'll tell you the story. It was a very interesting story. So he
Okay.
said to me, I quite like some of my guys, especially like to keep spreadsheets of their improvement, their reduction in symptoms, because the symptoms can be quite complex in many. So it's not just is your pain better, but is your erectile function better? How strong was your ejaculation? Did you have pain after ejaculation, and how long did that last for? So there's a lot of complicated things there. And he opened up his spreadsheet, and I tend to use a traffic light system for them. So I'll say green, you're fine, amber, not so good, red, bit of a flare.
Mm.
So he showed me his spreadsheet, which was all colored in from 2 years ago, and it was basically red. The whole
Okay.
thing was red.
Yeah.
And I said, okay, that's fine. And I don't really, I'm not a big, I'm not a big visual analog scale or
Mm.
0 out of 10 person,
Me neither.
unless I'm really looking for an immediate change on something I've done clinically.
Mm.
But I kind of, because I think pelvic pain, pelvic dysfunction experience is maybe too complex to kind of break down into a number, and they get sometimes a bit annoyed by you when you say, "Well, I don't know how to even answer that." So anyway,
Yeah.
he showed me his, and they like the, I don't know, if they're visual, they like, and a lot of guys are visual, they like to keep it simple. So he showed me, and it was all red. It maybe had a couple of green bits, a green bit here, a green bit there, but it had this whole thing.
Mm.
And he'd obviously been very diligent at filling it in. And I think so anyway, it doesn't matter. He got the next one out, and I said to him, "So how are you feeling?" I said, "So how much better are you from the beginning? Maybe we need to let's take a pause. Let's sit back.
Mm.
You tell me where you think you are. I'll tell you where I think where you are, and let's see where are we going to go next with this. What do we do? What does the rest of the journey look like from here?" And he said, "I said, well, how much better are you?" He said, "Oh well, I'm better." And I said, "Can you give it a number?" He went, "No." I said, "Okay.
Okay.
Can you show me your spreadsheet?" And he opened the spreadsheet up, and it was green and green and green and green and green and green,
Ah.
red, red, green, green, green. So I went, "Can you take a screenshot of the red one? Send it to me." Right. Okay. So I had it on my phone. I said, "Now open the green one up." And I put them side by side, and I said, "So what do you think when you look at those two things?"
Mm.
And he went, "I think I'm a lot better than I think I am." And he said, "I've never looked at them side by side before."
Yeah.
And I said, "Well, okay." So anyway, it's kind of like, it was interesting because, and he is a lot better.
Mm.
Um, and he then said to me, "So do you think this is as good as I'll get?" And I said, "Well, I don't know." I said, You've done super well." He said, "Well, I could probably live with this. I could probably go and live my life with this,
Mm.
but I'm not sure that I want to." And I said, "Okay, well," I said, "let me," I said, "Well, look, let me go away and think
Mm.
about this." I said, "Because I want to reflect upon it myself." I said, "Because I don't just want to say, absolutely, we can get rid of all of this. Come back and see me and I will
Mm.
fix you." Because it's very tempting
Mm.
to
Yes.
go,
Yeah.
"Well, you were red and now you're all green. Look what I've done. I'm amazing. Fantastic." But in actual fact, I know that the work's been done by him.
Mm.
I've just been on his journey with him, and he's done an amazing job. Um, and then he started saying things like, so one of the things was he'd been a big weightlifter before,
Right.
lifted weights in the gym. And there's a big kind of thing out there, a mythical thing in the literature, that if you've got pelvic floor dysfunction, non-relaxing pelvic floor, or chronic pelvic pain, that you shouldn't lift weights.
Ooh.
And a lot of the guys, it's a bit of a mythical layman's thing, and that will say, "Oh, some guys do it lifting weights." So you have to take them back to it, like, hurting your back by bending and lifting. You're not ever going to not bend and lift again, but you have
Mm.
to go back to it in a graduated, safe way, building your resilience and your tolerance and your sense that you're okay with it. So these guys, but I really like loading my guys up. I like getting them in the gym. And if they don't go to the gym, I like them to load themselves up at home. I like to do like physical, practical exercise, because I think the pelvic floor lends itself to that. One of its job is load transfer. And so to restore its ability to transfer load, I think in my mind is super important.
Mm.
So I said to him, he started saying to me, "Well, I don't think I told you, but I've gone back to deadlift." And he'd completely stopped lifting weights. And he
Oh.
said, I said, "So now," he said, I'm squatting 40 kilos. and I'm deadlifting 60. He said, I used to do 140. I said, okay, that's okay. That's up here in the spectrum and you're down here. But I said, weightlifting is only ever about increasing gradually. I said,
Yeah.
so we just see how you go. And so it's really interesting how when we broke it down and we had the time to have this conversation,
Yeah.
because he said to me, I said, so at the very beginning, I said, how are you doing? Yeah, I'm a bit better. Yeah. And I'm kind of inside, I'm looking at this going, you're not a bit better, you're amazingly better. But
Yeah.
that's what I
Yeah.
feel. But he felt he was a bit better
Mm.
because for him, the kind of lack of him being able to get back to everything he was doing before
Mm.
was still a barrier to him.
Yeah.
And I said to him, well, look, who knows? You've come this far. You've done really well. I
Mm.
said, we maybe need to step back. We need to reframe how we go forward with you.
Yeah.
Maybe we need to focus more on the strength training and the loading, and
Mm.
maybe we need to focus less on trying to diminish your symptoms because he also has some um, post ejaculatory pain, which
Okay.
is and I kind of like because all the I think pain, as you know, can be really overwhelming,
Mm.
and it's quite easy sometimes in the pelvic health thing to compartmentalize and say, so that's your pain you get at the gym when you do that, and that's your pain you get over here,
Yeah.
which is connected to a much more because I mean, sex is, I think you were laughing because you said you'd heard me say that sex was a sperm deposition function in a lecture with
Mm.
Michelle. And I think what we've done with sex is we've taken something that's not meant to last very long at all
Mm.
and is about exactly that. But we've turned it into connection, trust, loyalty,
Mm.
pleasure, more than just one thing. So that's a very complex thing to address
Yeah.
because it's not just as simple as saying, well, don't have sex,
Mm.
because don't have sex creates all sorts of social
Mm.
situations between you and your partner
Mm.
with with guys that have sex with pain tend to distance themselves from the partner. So there's a kind of in the first thing that goes is intimacy. So
Mm.
they don't hold hands and they don't cuddle because they're worried that holding hands and cuddling will lead to sex.
Okay.
And so therefore they will stop holding hands and cuddling.
Okay.
And then so that there's a big kind of cat chasm, I suppose, opens up between the two people. And then that distance can be very emotionally difficult when you need help and support because if the intimacy isn't there, getting that help and support is quite hard.
Mm.
So you kind of tend to treat that a little bit differently from the gym and separate those things out a little bit. So yeah.
How
Yeah,
have you
interesting patient.
how have you found? I guess it depends on how, as you say, letting them talk, asking, being willing to ask the deep questions. But as you also
Yeah.
said, men can be quite at times a bit, I would say, stiff upper lip, kind of, defensive.
Yeah.
Not, it's not always what
All
they
of
used to
that.
talk
Yeah.
about. So, any ways you found that helps them open up, and being willing to talk about whether it's pelvic related or it could be erectile function or sexual,
So I think, yeah, I mean, I think it's a good question. I think sometimes that unwillingness to open up can
Mm.
be a strength in some situations. So
Yeah.
it's not always because maybe perhaps just letting everything come out is too much. It can be
Mm.
overwhelming. It can be, and maybe at the end of that, maybe there is no positive shift because actually what we're looking for, isn't it, is some kind of shift
Yeah.
in how they believe what's happening, how they trust what's happening, how they trust us. I think if I so I'm trying to think. I'm just trying to think of examples. I had a guy recently who is 62, 63, post prostatectomy.
Mm.
Came in, he's could be wrong. Let me just say he's 7 months post prostatectomy, and his wife brought him.
Oh,
Okay,
okay.
so his wife brought him
Yeah.
because so at that point after post prostatectomy, within a few days, weeks, you would expect post prostatectomy guys to be dry at night.
Okay.
Within a few months, you would expect them to be down to maybe one pad a day. Within 3 or 4 months, you'd expect them to be dry. So he was still, let's just say randomly, that's the figure. For
Mm.
him, he was still leaking at 4 or 5 months, and he
Mm.
was probably on about maybe 8 pads a day.
Okay. Wow.
He had stopped, but so from a whole kind of lifestyle, he wasn't golfing, so he wasn't seeing his mates. So he didn't want to go for dinner because he was afraid that he would wet himself.
Mm.
It had absolutely taken his sphere of living and compressed it to the tiniest space.
Yeah.
And he had been I have this thing, right, that teaching men to retrain the pelvic floor is different from treating women.
Mm.
And what sometimes happens, not always, because there's some fantastic pelvic health physios out there. I'm going to say that first and foremost. But sometimes these guys slip under the wire
Mm.
and they get given a sheet of exercises that tells them how to contract the pelvic floor.
Right.
Now, one of the problems with that is that as men,
Yeah.
we think that our pelvic floor function is a gift from the gods. Okay.
Okay.
We have no idea how it
Mm.
works.
No.
We don't even know our erections are to do with muscles.
No.
We know our erections are to do with blood, but only because of pharmaceutical adverts for Viagra. That's it. So we've learned stuff, but we don't inherently have this interoceptive connection with our pelvic floor. So if I said to some guy, tighten your pelvic floor, no idea.
No.
But if
No.
I said to a guy, make your pelvic floor move the same way you would do it when your penis has got an erection and you make it bounce up and down, they go,
Ah.
oh, everyone smiles. Boom, 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 boom. Because they've done it and
Yeah.
they
Yeah.
know it and they've
Yeah.
learned it. They don't actually understand what it is, but they've had that embodied experience that that has happened. So this guy, anyway, these guys, they come in, they have no idea. They take their piece of paper, go away, and they do their clenching, okay?
Mm.
Or they
Yeah.
do, and then they get the Squeezy app, which again is a fantastic app, a fantastic help for to get guys to remember to do their exercises and encourage them to do it. But if they're not doing it correctly to begin with, they're doing the exercise, but they're doing it incorrectly. They're doing it inefficiently. They're not recruiting properly. They're not maybe making sure that their pressure system, their intra-abdominal pressure, is not bearing down because there's different ways to get continence.
Mm.
And the other thing that we know from research, from ultrasound research, is that the pelvic floor in men works differently to the pelvic floor in women.
Right.
And a lot of the, so if they go online to look up Kegels, Kegels are really for women.
Oh.
Men have to do something different because our urethra is longer. So
Right.
we have to kink our garden hose as well as turn off the spigot. Girls just
Okay.
have to turn off the spigot.
Yeah.
So when, so I went into the room and there was a lot of this. Okay. And I thought, okay. And he looked super angry, which I knew why, because he was like his erection function's not come back. He's a
Mm.
relatively young 60 plus year old, right? Who has a relatively young wife and they're not having sex. So everything that his golf, his mates, sex with his wife, everything that was who he was,
Mm.
everything that as a person who he exemplified
Yeah.
had gone.
Yeah.
And he felt
Mm.
absolutely humbled and vulnerable. And what did wounded animals do if you try to approach them? Is they fight, they lash out,
Mm.
he was, and it was very interesting time to talk to him because he didn't really want to say very much, and his wife was doing quite a lot of the talking. And then I thought, okay, that's I thought that's completely acceptable considering where he is in his headspace at the moment.
Mm.
And I thought, so today I'm not going to be able to turn this around for him. All I'm going to have to hope that so I did my assessment. I use ultrasound imaging. I do an internal exam because he
Mm.
was quite far down the road, and I checked out. I said, well, look, you're not doing the contraction correctly. and your coordination is wrong. The way you're recruiting is not the best way.
Mm.
He said, so I really need to change a few things. So he got that, we changed it. And so the next day, I actually thought at that time, I thought he was about, I don't know, 5'7". I thought he
Okay.
was quite small, which is really, I'm telling you that, you'll understand this in a reason, right? So the next time he came in, I sent him away, and I always do this thing where I video everything that I instruct them in so that
Yeah.
they don't need to remember anything. They take all of that away,
Yeah.
and maybe even the interview as well, so that they can listen
Mm.
and reflect and come back to me with questions. Because I think that's really useful, so that if they don't come back and say, "Well, you said this, Bill." I say, "Oh, I don't think I did. I think if you listen to 2.3 minutes on that, you'll see that I didn't say that."
Yeah.
But anyway, he came back and he was in the chair, and he looked about 6'10". Like he
Oh.
looked like he was just this big tall guy. And I went, "That's weird. I thought you were like really small." And his wife was there again, but she was, and the whole mood had changed. And he was down to one pad a day. He could golf without leaking. His erections hadn't come back, but he said, he said to me, "I'm okay with that because you explained to me, which I didn't understand before, that that can take up to 18 months. So I know I'm on a journey for that. So
Mm.
I'm okay with that because now I can go. We've been out for dinner. We're actually going away for the weekend. So all I really did was kind of give him the space to have his life back,
Yeah.
well, by getting his pelvic floor. I didn't, make him completely dry, but
Mm.
he will be. But it's kind of, yeah. So I think it's that you go in sometimes, isn't it? And you think, okay, how am I going to handle this guy? Different. So although they're all men, they're all quite different.
Yeah.
Yeah. So I don't know. Did that even answer your question? I
Well,
don't
like, I
know.
think it sounds like, and all men are going to be different, aren't they? You're going to have some which are very willing to talk about it, and
Yeah,
others
100%.
which
Yeah,
aren't.
yeah,
Um, and just give it, as you say, give them the space. And as you say, the VAS, I haven't asked VAS numbers for years as well,
yeah, yeah.
because
Good.
that can change day to day, and
Yeah,
really, it's about the effect it's having on their life.
100%. Yeah. It's like that lived experience of what this means to them. It's like, like if you say to somebody, I don't know, if you're an elite level masters runner,
Mm.
and you're leaking when you run because you've had a prostatectomy,
Mm.
you're going to want to maybe get back to be able to run without leaking.
Mm.
If you're a bit more sedentary, you're 62, you love your grandkids, and all you do is when you pick your granddaughter up, you leak. You want to be able to pick your granddaughter up and not
Mm.
leak. So it's, what do you want to do? It's
Mm.
like, what do you actually want to do? Like, it's not what I want to give you or what I think you need. What do you want? What can I give you? How can I help you get back to living your life
Yeah.
the best way for you? What would be the best outcome for you? And it's really funny. I had a guy, a long time ago. So you sometimes see pelvic patients for quite a long time, and this guy I've known for 20 years,
Mm.
and he has had pelvic pain for 42.
Mm.
And when
Wow.
he came to 42 years,
Wow.
he's an amazing chap. I will say this, right? I have learned more from him than he has learned from me, okay?
Okay. Yeah.
Because he is the most erudite, willing to share gentleman you could ever meet.
Okay.
And when he came to see me, he had 15 different symptoms, and they were all quite specific. And he'd had various injections, nerve blocks, ridiculous. He'd had radio frequency ablation. You name it. He had had everything.
Mm.
The only thing he hadn't had done was he hadn't gone to France for nerve decompression surgery. That was the only thing he hadn't done.
Okay.
And anyway, to cut a long story short, he came to see me for a bit and then he went away for a bit. So he went from being 15 different symptoms to maybe three or four.
Okay.
And he went from um pretty much not going out to meeting his wife, having a child, having
Yeah.
a life.
Yeah. Yeah.
And I didn't see him for a wee while.
Mm.
And then, but he would kind of pop an email or something going, "Yeah, I've still got a bit of this, but I'm managing," and bish bash bosh. And then he came to me and he said, well, I'm a bit fed up with this. He said, because actually my ejaculatory pain is every time I ejaculate, it's 3 or 4 weeks of pain flare up and I don't know what to do with it. I said, okay, well, do you want to, well, we can have a look. We haven't seen you for a little while. If you want to come back, we can have a look at that and see what we can do.
Mm.
And so we came back and I think he had, I think he probably had still three symptoms at that point. The biggest one that was really bothering him was post-ejaculatory pain.
Okay.
And then I said to him, so how are you doing? And we treated him for maybe, and I did a lot of, so what I did was, because I suppose people listening might want to know what I did. So what I did was I did a bit of, I kind of think that sometimes with the control of the pelvic floor is that there's kind of um, peripheral neuropathy. There's like a temporary neuropraxia with a neural inflammation.
Yeah.
And so what I did was I kind of follow Anna Schmidt's work from Oxford, and
Hmm.
Anna's done lots of research on not pelvic peripheral neuropathy, but carpal tunnel,
Yes.
antecubital radiculopathy. So I kind of look at the broad ideas that she has around that, and I either make space for the nerve by reducing tension and muscle or
Mm.
showing the patient how to do that themselves, and then mobilize the nerve itself within the pelvic cavity, which is quite, it's a bit unique, but it gets some decent results on individual patients. But there's not been any research to say that that it's a valid thing to do. There's some evidence that changing the neuropathomechanics in peripheral nerves and with peripheral neuropathy can help in other nerves, but not in the pelvis. So
Okay. Mm.
anyway, we he said to me, it's really interesting, isn't it, how different types of pain patients are different. And he said to me, well, I'm a lot better because now I only have pain after I ejaculate for 2 weeks.
Okay. Okay.
And I said, okay, okay. And then recently I was speaking to him because he'd only come back recently to see me about this. And he said, so it's definitely getting better because now I only have pain after I ejaculate for 1 week.
Right.
And
Ooh.
I said, okay. And then the other day he sent me an email going, I thought you'd want an update. 3 days. It's a
Ooh.
miracle.
3 days. Okay.
And I'm thinking, okay, so what? And that all I can do is base on what he's telling me. Like
Yes.
I don't really know exactly if it's what I'm doing or if it's something else. Is he just relaxing into it? Is
Mm.
he not? Is he learning to? We did a whole bunch of stuff about. Um, so you become a bit of a kind of a become a bit. You have to know about a lot of different things in pelvic health. So you become a
Mm.
bit like, look, we did this big chat about how ejaculation and orgasm are two separate things,
Mm.
and that we just tend to ejaculate and orgasm at the same time. But actually,
Mm.
you don't need to do that. So you could actually have sex and an orgasm and not ejaculate.
Mm.
And he went, oh, he said, how can you do that? I said, I've got no idea. Because I think my pelvic function is a gift from the gods. I said, I don't know. And so he said, okay. I said, maybe perhaps if you look at the physics of during sex, your pelvic floor muscles, your your levator ani, your pubicoccygeuus, they all wrap around the base of the bulb of your penis and they start to squeeze and they squeeze and squeeze and squeeze. And that's part of your enjoyment and sense of feeling till you get to a threshold where you deposit sperm into your vas deferens and then you reach a threshold, you go over the threshold and then you squeeze your pelvic floor and your semen shoots out the top and you have a brain orgasm. So you
Ah,
have a thing in your head. But for us, we're a bit phallocentric. So we kind of think we feel it here,
yes.
but actually we feel it um, in our heads. And I'll tell you something about really interesting about
Okay.
that in a minute. So he said, oh, I said, so maybe you just need to relax. And maybe you don't need to think that you have to do this big hip thrusting thing to make that happen. And he was like, oh, well, maybe. So I'll maybe try it. Maybe I'll try that. So I don't know. We'll see how that goes.
Okay.
However, the one thing I've learned is there's a group of men in So sometimes after you have a prostatectomy, you have a nerve damage to your cavernosal nerves. That means that return to full erectile function is not possible.
Mm,
And they give men this horrible term, impotence, which
yeah.
actually is a horrible term. It's a term I think that I just don't. We should find some other way of describing them.
Mm,
And the idea is that it's based on the idea that to have sex, proper sex, you need to have a rampant hard penis that you can put inside a vagina. And any other kind of sex is less than that gold standard. Okay. So there's this fantastic group of guys who are American
right.
who have had prostatectomies that are impotent,
Okay.
and they call themselves the Soft Cock Club.
Okay.
And they have sex with non-erect penises with their
Okay.
partners. Okay.
Mm.
And guess what? They can orgasm. You
Oh.
do not need an erection to orgasm, which
Mm.
is, and I remember reading it and thinking, wow, that's,
Mm.
well, that's news to me, but good news to me, because in actual fact, that's a really interesting thing to look at people who do have that nerve damage post prostatectomy,
Mm.
because there's ways of, it, because they are man, and the second thing that happened was I had a guy recently who won't mind me telling you his story, but he was quite young. He was, I'm going to say 49.
Okay.
I think 49, and he had prostate cancer, and he had to have a radical prostatectomy,
Mm.
and but he was also super strong. He was a weight trainer, very fit, judo guy,
Oh yeah.
trained every day, and I was lucky enough with him to see him pre-op, so we could check his pelvic floor before he had the operation, and then he went off and had the surgery, and then he came back, and he went from surgery, post surgery, to completely continent within about 3 weeks.
Wow.
He went to full erectile function um, in 16 weeks,
Wow.
which was really interesting. Now, that was interesting in itself. It's one of those things I actually need to write that up, because I think as a case study, it's kind of astounding. But the interesting thing about that for me was he said
Mm.
to me, but there's something else, Bill, and I want to tell you this. Talking about what guys will tell you and what they won't tell you. And he said, I want to tell you, so if you have your prostate removed, 75-85% of your ejaculate is prostatic fluid. So, when they remove your prostate, they remove your urethra and they remove your external urethral sphincter.
Right.
So when you ejaculate sperm, it goes into your bladder. So you retrograde ejaculate. So you don't ejaculate anything other than maybe perhaps some seminal fluid from your seminal vesicles if they leave those. And so you have this, again, dry ejaculate and or dry ejaculation. And he said to me, it was weird the first time, weird the second time, he said. And then the third time, he said, I realized I was having the best orgasms of my life. He
Oh,
said, I was
okay.
actually having these orgasms that were just all over my head to foot. He said, he said, because I wasn't focusing on the ejaculatory component of my
Mm.
orgasm. And he said, so sex for me has changed completely. He
Wow.
said, and actually, you could argue maybe for the better.
Mm.
So I mean, I'm learning stuff all the time, because there's nothing written about this
Mm.
anywhere. There's no real research. Not that I can find anyway, because I've gone and tried to find stuff, and
Yeah.
there's nobody speaking about it, because I think, once your life is saved, once your prostate cancer's away, you just totter off and you just live your life, and you
Yeah.
and if that happens, you maybe just think, oh, that's probably. I think if guys don't talk to each other, then it's like, well, maybe that's what happens to everybody, or
Mm.
yeah, I'm not going to have that conversation. I don't know. It's yeah. So yeah, interesting story though. Interesting
The
story.
It's a bit maybe a dumb question, Bill. The soft cock club,
Yeah,
they can get an orgasm.
yeah.
Uh, Dumb question. Can they do they still ejaculate or not?
No, so they're
No.
post prostatectomy. So they've had their prostates removed, their urethra removed, their prostatic urethra removed, their external sphincter, and they might still produce sperm, but that would be it would go into their bladder.
Okay. Okay.
So they wouldn't ejaculate at all. So they have a completely dry. They don't even have an ejaculation. They just have an orgasm,
Mm.
um, which is kind of. Um, amazing, really, I think.
Yeah,
Yeah.
well, yeah,
And
yes, I
actually,
feel that.
yeah, it needs to be looked at, needs to be researched. We need to understand that. I think that actual situation needs to be really investigated. It would help us understand kind of men's
Mm,
sexual function much, much better, I think,
yeah.
if we understood that. Yeah. And they are an amazing group of resilient men as well. So, yeah, quite clever, quite
Yeah, I
clever.
feel like it's you were saying about, they have the surgery and they get on with it. It almost when those situations happen, is it not that I've ever been through it myself or know many people who have, and I don't see these kind of patients, but I'm going to make an assumption here. The fact that they've had their cancer treated,
Yeah,
right? That bit's been
yeah,
the
yeah,
life-threatening bit's gone.
yeah, yeah, yeah,
Are they told, well, this is just the sacrifice for you still being alive? Is that how
yeah.
it's told to be?
Yeah, and I think the thing is there's a journey here as well if you're a cancer patient. So you often go along perhaps for a test because you're symptom free. So a lot of people with prostate cancer have no symptoms. So you go along and you're tested because there's an issue, or you're 65, or there's a familial history, or maybe you have the initial signs of changes in your prostate, like benign prostatic hyperplasia. You're getting up at night for a pee.
Mm,
You feel that you need to go, and when you get there, you can't go.
yeah.
And so you go along and um, you go to the GP just because you think you should, not maybe even expecting there's going to be anything. You get a PSA, a prostatic specific antigen test, and that comes back as high. And then they maybe do a digital rectal exam, and then and suddenly this thing, then the whole system moves quite quickly,
Yeah.
and suddenly you're having a biopsy, and suddenly it's cancer.
Yeah.
And also it's cancer, and you've got they score it using a thing called the Gleason score, and 7 and above means we need to do something about it. So maybe you've got a high Gleason and they're saying, yeah, we need to remove this, and suddenly there's this kind of whirlwind of, my goodness, I was actually well 2 or 3 weeks
Yes.
ago, and
Yeah.
now I have cancer, and
Mm,
now I need an operation. And there's a lot of stats that are presented to you about the outcomes, about what the difference, so whether you do brachytherapy or whether you do radiotherapy or whether you do um, sort of um, androthics and they give you hormones, or whether it is full on surgery. And so there's a kind of I suppose there's an urgency as well to
mm,
that, because
mm,
they want to make sure they can do it as quickly as they can. And often your partner saying, "Don't worry about all of it. Just go get it done. We just want you to be alive." So
yeah.
that, yeah, absolutely 100%, that becomes and that's a valid argument and position to have. There was a paper written by an Australian physio that looked at the kind of the oftentimes guys weren't told about the sexual negative sexual outcomes,
Oh,
and,
really?
or maybe not as maybe clearly as they
Mm,
could have been. Although I think that has definitely changed, and certainly with the consultants that I work with, all of the guys the explanations are given exactly like they're consented. But I think it's sometimes, what do you hear as well? Because you've just been told you've got cancer and that you need an operation, and
yeah.
the next thing you're thinking is, I've got cancer, and the doctor's still talking, and you're going, I've got cancer, I've got cancer, I've
Yeah.
got cancer, I've got
Yeah.
cancer. You
Yeah.
don't really hear very much of the other stuff.
Yeah.
And I think there's also a little bit like sometimes there is that situation where we've saved your life, so it is a bit of a sacrifice, the fact that you don't get an erection, or that you pee yourself a little bit. Although I think more and more, I think prostate surgery has become incredibly kind of specific and technical, and so a lot of surgeons are very, very, very good at doing, especially robotic
Mm,
prostate surgery is very good at sparing nerves, so that the prostate, the pelvic floor function, and the erectile function can work better. So
okay. Mhm.
it's a tough one, because I think, you're right that it's a life-saving operation. You have to save your life, and that's first and foremost. And then
Mm,
it's and then it can be quite a long recovery
yeah.
post surgery for the erectile function to come back.
Okay.
Um, and we know we've got some evidence that pelvic floor. We've got some level 1A evidence that pelvic floor muscle training can help incontinence. I mean, we've got level 1A evidence that we've got no, that's not quite true. Well, we've got a decent couple of studies that show that if you do fairly intensive um, focused pelvic floor rehab, you can improve the rate of recovery from incontinence and improve the rate of recovery for erectile function as well.
Wow.
Joe Melios's paper is a great paper that shows that. We've got some work from Grace Dory way back in the 80s that showed not guys with prostate dysfunction, but guys who had erectile dysfunction for different reasons. If you put a pelvic floor muscle training program in place, it made a big difference. 40% of them got better.
Yeah.
So I think we're getting better at prescribing the exercise. We're getting better at managing that and
Yeah.
assessing the outcomes of that, really. So, and I think we will get better in the next few years as well, because I think we're getting much better at the idea that I think I spoke to Joe not that long ago, and we were talking about the idea that everything pelvic floor rehab in the last 20 to 30 years was kind of something you did on a bed with lying on your back with your knees bent up.
Mm.
And now we're much more get people off the bed a little bit the way that back pain rehab has gone from, we get them functional,
Oh, yes.
get them
Yeah.
lifting weights, get them doing stuff
Yeah. Yeah.
that
Yeah.
represents what they're going to need to do when they go back.
Yeah.
So that functional training, we don't have much evidence for that, but definitely that there's a big space in the research looking at the application of functional training
Mm.
to restore erectile function. Because the thing about sexual function, pel pelvic floor rehab, it can be about isolated pelvic floor muscle contraction, and it can be in different positions. But sex isn't isolated pelvic floor muscle contraction. It's hip extension and flexion. It's
Yeah.
lumbar spine.
Yeah.
It's hip thrusts. It's knee bend. It's one leg on the bed. It's
Yeah.
it's in side lying. It's in plank. It's in mission. It's in all of those positions.
Mm.
And so I have a kind of a program, a functional program that I use a lot with my guys. Where I say, so a typical example is a guy says, well, I'm okay, I can get hard, I can maintain my erection, I roll over onto my side and I lose my erection. I said, fine. You need to practice getting your erection in side lying.
Mm.
You need to practice masturbating and moving from supine to side lying. You need to have an erection when you do it. Okay, that's fine, Bill. That's a lot better. Now I lose my erection when I hip thrust. Fine. You need to get some weights in your house so you can do hip thrusts with an erection. You need to have your penis erect while you move your hips because it needs to be. So this whole thing, and they look at it and go, "Oh, that makes sense." I went, "I know. Go try that." Yeah, I said,
Yeah.
it's what you do. You need to. It's like if you came to me and I said, "Let's do some isolated quads work." Okay, yeah. Now you can start running for your run. Okay. Uh, okay.
Nice. Yeah.
Nothing in between. No, I said,
Yeah.
no, I said, no, just start running. I said, so let's look at sex. It's an activity of daily living. Break it down into its component parts. What's the kinesiology? Where do you have a problem with
Mm.
that? Is it strength? Is it endurance? Is it
Mm.
power?
Mm.
Tease out the strength and conditioning principles and apply the principles for strength, endurance, and power. Simple as that. Nothing more. And I use strength and conditioning principles in my pelvic floor patients all the time
Mm.
to say, just think of them as skeletal muscles. They happen to be skeletal muscles with a high number of slow twitch fibers, but they still are skeletal muscles and they still
Mm.
have some fast twitch fibers. But you would just treat that the same as you would another skeletal muscle. You would treat, what do you want to do? Okay, let's see if we can figure out a plan to make that happen for you. So,
Mm. Yeah,
and by
quite
that
functional,
point,
as you say.
they normally would believe anything you say, and they're totally happy for you to listen to what you've got to say as well.
You gave the example of the guy who was, we said 16 weeks after his prostatectomy.
Yeah,
He wasn't particularly keen to be there initially.
yeah.
What's another hard or one of your hardest conversations you've had?
One of my hardest conversations is,
No pun intended as well.
no, it's all right. So I think one of the hardest groups of guys that I treat are young guys under maybe anywhere between 18 and 25.
Hmm.
And they have a condition which is not even necessarily well recognized in the medical field called hard flaccid syndrome.
Right.
And we don't know if hard flaccid syndrome sits underneath the complex pelvic pain dysfunction umbrella, or whether it sits somewhere on the spectrum of erectile dysfunction. But basically what they report, and it's not really, it's really patient reports. There's been two papers in the Journal of Urology talking about it. They
Okay.
have a semi-erect penis that is turgid for most of the time, doesn't really go completely soft. It can have a band of thickening at the bottom, and it feels very kind of rubbery and uncomfortable.
Yeah.
And they have a cold glands. So those guys have, and they find it difficult to maybe get erections, or erections are painful, and they find that they can't maybe fully ejaculate. So sensory stimulus
Mm.
is altered,
Yeah.
and it really disturbs them. And those guys often they're often quite young.
Yeah.
They are often quite frustrated because they've been through the urology route, and nobody's really picked up this is what's happening with them because it's not really acknowledged. It's a bit like when fibromyalgia wasn't a thing. Or a bit,
Yes. Oh, yes.
it's a bit like when people, oh, you don't have that. That doesn't exist.
Mm.
It's that kind of time. It's a novel medical diagnosis,
Yeah.
and so they are a difficult group to speak to because they don't they often don't trust medical people by that point.
Mm.
So they have come in with a lack of trust, and they're very extremely desperate because they're
Mm.
at a stage in their life when they expected to be having lots of sex with a partner, or lots of
Yes.
multiple partners, or
Yeah.
have it, being 18, being 19, whatever, whatever that meant for them. And
Mm.
whatever it is that they see it meant, they're not doing the life that they thought they were going to be doing, really.
Mm.
And so they are quite difficult to treat because they maybe don't have that life perspective
Mm.
where you say to them, you're quite young and you have your whole life ahead of you, because the only thing they see is here, now, today,
Yeah.
maybe
Yeah.
tomorrow. They
Yeah.
haven't, they don't think. So if you say things to them like, it might take a year to get better, it's like, oh my, like, what do you mean a year? A year, like, I'll be ancient by then, I'll be 19. I'll be like, but for them, and they see it, that they're quite emotional about time passing,
Mm.
birthdays, Christmases, Easter, milestones along their journey when they're not any better.
Yeah.
And they tend to have a lot of catastrophization, and they tend to have a lot of rumination,
Mm.
and they tend to have a lot of all of the kind of things that we see in chronic pelvic pain patients, really, or
Mm.
chronic pain patients generally,
Mm.
that we can see. Um, but they seem just that much more intense because they're often tied in with their identity of who they are as young men.
Mm.
And so they are quite difficult because
Mm.
there's sometimes an awful lot of repetition, support, encouragement that sometimes you often feel falls on deaf ears,
Mm.
and they can't process maybe as well and see that digging in and building some resilience to the journey ahead is either worthwhile to them because they want this instant fix. And I don't know, I'm not sure if it's something to do with social media
Mm.
and Instagram and Snapchat, which is instant and snappy and
Yeah.
everything boom, 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 boom. So there,
Mm.
and everything on there, everyone is happy. And if there's a problem, it gets solved, and people post how they solved their problems and how easy that was. And weren't they glad they did it? And
Mm.
you should do this.
Yeah.
And so I think that there's a lot of, and they're quite embedded in social media. I think that generation,
Definitely.
they walk about like this, they can't
Definitely.
not
Yeah.
have their phones. And I think I read an article by a psychologist that was talking about kids and how kids get really super upset when their parents take their phones away from them. And he said, well,
Mm.
it's very he said, why would they not? He said, because it's like you going to the grocery shop with a shopping list, and you get there and you go to shop and you've forgotten it. and you get frustrated by yourself. He said, because that's an analog extension of your consciousness.
Mm.
And the only thing you had on that piece of paper was your shopping list. Imagine the digital extension of your consciousness, which is your phone,
Mm.
and someone takes that away from you. They're taking away knowledge, connection,
Yes.
all sorts of things to do with your whole who you are and who your friends are and how you all connect together. He
Mm.
said, so you're taking away a part of them, even
Mm.
although they can't tell you that and you don't know that. And I
Mm.
think so these guys, they're so I think that's I don't think there's one I, I I find that those are the most difficult guys
Mm.
to talk to and deal with.
Yeah.
Because I have to reframe my position with them and I have to take a big breath
Mm.
and know that they're going to be super resistant to
Mhm.
what I suggest, and that to get them on board is going to sometimes be very difficult.
Yeah.
And I think, but I like that challenge. I think they are. I think I was hearing an Australian physio talk about a burnout in physiotherapy the other
Mm.
day. An American physio, I think, was interviewing this Australian physio, and they were talking about burnout, especially in pelvic health, where it can be really intense. And I think that group of patients tends to be the patients that you have to reflect upon and think, is that pushing you towards that
Yeah.
situation? You sometimes I find I have a kind of a thing where if I've had a heavy day of
Mm.
pelvic floor patients, that I'll take some time at the end of the day to sit in the room and try to reflect upon my difficult patients and say, okay, so did I achieve anything with that today? Did I actually? And I think, yeah, I think maybe that and that. So I didn't, so there's two things there that we made headway on. So I'll think, okay, that's good. I think, okay, that's good. So for next time, I can make a little plan for what I'm going to do. And so I kind of like filter it through my brain and think, okay, so and try not to take it home with me,
Mm.
because it's just all encompassing for these guys. And I totally understand that. I totally get
Mm.
it and I empathize. But I think as an empathetic, in our profession, we tend to be empathetic. So I think you have to be sure that we have some space for us that
Mm.
is away from that and that you can disassociate from that and it doesn't, otherwise you would burn out and it would be too difficult to do the job. I think you sometimes have to almost kind of I think I'm quite good at listening to quite difficult stories
Mm.
and trying to objectify them and say where is it that I can fit? What skill set do I have
Yeah.
that I can help this person
Yeah.
on their journey to being a bit better?
Mm.
Rather than because I think not so much, I don't want to fix them, I don't want to cure them. I just want to say, how can I help you find the way? What's the
Mm.
path for you
Yeah.
back to healthier, happier you, I think.
The path may not always involve us. It may
No,
involve other people.
yes,
But you may
100%.
be the first person that they tell about
Yeah,
whatever the thing is.
100%.
And
Yeah, yeah,
some people that's the breakthrough in itself. You may not
yeah,
have done, I say
yeah,
done that in air quotes, but physically or
yeah,
advised on this thing, anything. But
exactly.
actually, the fact that you've allowed them to say that and you've then directed it wherever,
Yeah, 100%.
actually done something in the long term
And
is quite
I had a
massive.
chap recently who I had, funny, it doesn't, a long story, but I saw him during lockdown, saw him online, helped him out, did really well, but he hadn't gone back to being sexually active. And he had messaged me to say, I think I need to come back to see you. And I said, you don't.
No.
And he said, what do you mean? I said, you don't. I said, I'd like you just to go out and date. I said, and go and meet people and go and do stuff and get back, just get back into being who you were before.
Mm.
I said, and if that doesn't work, come back to me. I said, but just go and he didn't need me because he went off and he met a girlfriend, he had sex, and it worked fine.
Mm.
Uh, and I said, there you go. I told you, didn't need me. You were fine. And it's weird. I think in pelvic health, it is that thing you have to know when this is not my role.
Mm.
And that's a big psychological kind of experiential thing, I think,
Mm,
because I think I've done as much as I can possibly do for you. I
mm,
think now I said to him, you have to jump off the cliff. You have to go and just live your life. Go and
mm,
date, see where that goes.
mm.
Don't worry about it. Just go have sex.
Yeah.
And he actually the guys are brilliant in a way because I just wanted to let you know, Bill, everything's going well. Thanks very much. Good. Fine. Thanks for letting me know. Glad to hear. Good luck. Crack on.
Yeah.
So it's you have to, yeah, I think you have to look after yourself. You have to look out for them, but you have to
Mm,
look after yourself.
mm,
100% you can't. That's such an important thing. I think you said that sometimes their pathway to recovery
mm,
doesn't even involve us.
mm,
It doesn't. I mean, it's like we point them in that they're like ships that you set sail off across the sea. You point
mm.
them in the right direction and you give them a push and you
Yes.
hope that the tide carries them to the destination that they want to be at.
Yes.
So yeah,
There's been several people I'm thinking, yes, they sometimes, we can do suggest our various treatments and ideas and management strategies and all that, but actually, it'd be really good if they got a partner and just were
yeah,
more sexually active or had much more of a
100%.
relationship.
Yeah,
That would, for some people, do more good than anything we'd suggest at all.
100%. Yeah, I think that's so true. I think it's about, what we're about as human beings. It's about
Mm,
connection.
mm,
It's about having relationships.
mm,
It's about all of that. It's about living. It's about having, in pelvic health, it's often about having families, having babies.
mm.
Can that ever happen? I mean, how can that happen? Will I ever be able to have a family? Like all that all comes in. That's a whole other kind of sort of pressure that is on these guys
Mm.
as well, for
I was
sure.
thinking we do gym referrals to people with with their medical conditions. Maybe there should be dating app referrals as well.
Yeah.
They get a discount for a certain period of time.
It could be, absolutely. Please help me. Please help me. I have pelvic floor dysfunction. I need some help. And I think you become a bit like I think you're a sense maker, you're an advice giver, and I always say to my guys, I say the only thing I have to tell you about when you go out there and you want to have sex with someone for the first time, be honest and tell them you've had sexual flow dysfunction. Tell them that you don't know how it's going to work, and that
Mm.
if it doesn't work, it's probably the physiology that you're dealing with rather than them. I said
Mm.
because if you don't tell them that, they will absolutely believe it's them, and there is no coming back from that. I said, but if you tell them that, I said they're going to love the fact that you trust them enough. I said to be honest. I said, and they'll love the fact that you're man enough to be honest and brave enough to be honest. I said,
Mm.
and also I just think if you're going to do the most intimate thing with someone, you can at least say to them, I'm not quite sure how this is going to work, but I really would like to give it a go.
Give it a
Like
go.
go and try it because it's like you don't want to speak to them about it, but you're going to do it.
Mm.
And I used to say to my kids when they were younger, they're grown up now, but before they were sexually active, I used to say, look, guys, I would be talking to them about the relationships and they would be maybe a little bit reticent. And I'll say, listen, I only have one thing. I have one thing that I say. And I say this, if you're not big enough to talk about it, you're not big enough to do it. So once you can talk
Mm.
about it, crack on.
Okay, I
Go
like
ahead. I said,
that.
because if you can't talk about it, why are you thinking about doing it?
Mm.
Because it's an intimate thing and communication is about everything that we do. So communication is key. And if you can't communicate before you've done it,
Yeah,
how's it going to be after you've done it?
yeah.
So
Mm.
yeah, they probably didn't listen to me. They probably just did what they want.
Bill, you're keen for, and this isn't just physios listeners, healthcare professionals of all disciplines. You're keen for more people to get interested in male pelvic health, and you told me
Absolutely.
that you've trained 250 in the past couple of years,
Yeah, yeah.
and you've got trying to do another 250 within the next
Yep.
3 years.
Yep, that's right. Yeah, hopefully. Fingers crossed. Yeah.
Eh,
That's my plan. But I mean, if anyone's out there interested at all in men's health, you can the our POPG, which is our special interest group, the
Hmm.
physiotherapy special interest group for pelvic health, runs men's health courses. I run a men's health course. There's a couple of other ones out there that you can access that are advertised. Um, and if you've done female pelvic health, it's an easy shift into men's health, I think. But I think, and I would love to have more men in men's health as well. I think that's definitely on the up.
Good.
The place I had the most men on my course was Istanbul. I
Really?
had 40 people on the course, and I had 39 men and one woman. And
Wow.
so I would take 50-50 here. But it's sometimes I have four, sometimes I have six, sometimes I have eight. But it would be quite nice to have more men treating men. Uh,
Yeah.
and it's not that women can't treat them, but I think that some men would like that choice. And if we've got a few more men out there, it would be a good thing to do. So
Absolutely.
yeah, brilliant.
Absolutely. I've had by chance a couple of male pelvic health patients, pelvic pain patients, come through by accident because they've been referred for something else, but this happened to be at the same time. And actually, it was fine.
Yeah,
I'll
100%.
be honest, I didn't do anything, all the EMG, ultrasound, internal
Yeah,
stuff you do,
yeah,
but
yeah, yeah,
it was fine. There wasn't
yeah.
anything weird about it. And I think actually they liked talking to it with a fellow man.
I think they
Maybe
do.
made it
Yeah,
easier.
yeah. I think it's true. I think it's true. And I think you're right about that because I love my tech, I love my gadgets, but
Mm,
that's for me because I enjoy it and I like measuring and I like outcomes and I like to know that what I'm doing has a benefit and I can
mm,
quantify that benefit.
mm,
But during lockdown, I
mm,
treated an awful lot of guys
mm.
that I never met
Oh,
face to face,
yeah.
and they all got better.
Mm,
So I know I was kind of the old school where I thought, well, that's never going to work, is it? Well, turns out that it did.
it did.
And it might well be that maybe sometimes, hands-on stuff facilitates improvement, maybe facilitates a connection, maybe facilitates something to get better a bit faster. Um, maybe, but you could equally say that, a non-hands-on approach is going to get some change and is going to get some benefit. I believe. Yeah, for sure.
If people want to help with this, you've got Instagram and
Yeah,
LinkedIn, which I can put in the
yeah,
description,
yeah.
and Facebook, you said as well. Is that
Facebook
right?
as well. Yeah, yeah, for
Mm.
sure.
I will say there'll be a lot of men if listen to this who'll be most pleased that you said told them text doesn't supposed to last more than 2.5 minutes. Um, but I can only thank you for doing this with me, Bill, and sharing your tales. And I think, like I said, a lot of people has found this useful, and the fact that we can just get men feel more comfortable talking about their whatever pelvic condition or pelvic pain it is, then
Absolutely.
hopefully we can help a lot of people.
Well, thank you for having me. It's been a pleasure.
Likewise, Bill. Likewise, thank you.